Hi, my name is Tony Gillespie, and I'm with Indiana Minority Health Coalition. I'm the Vice President of Public Policy and Engagement.
And I'm Lauren Davis. I'm a reporter with Side Effects Public Media. This is the second part of our Happier Birthdays event, a two-part conversation on infant and maternal mortality in Indiana, and particularly how it affects our communities of color.
Side Effects Media partnered with Indiana Minority Health Coalition and the Indianapolis Recorder to shed light on this issue because generally our stats in the United States are the worst among developed countries. Indiana's rates are extremely concerning, and this is an issue that disproportionately affects Black moms and Black babies.
This is the second part of our event. If you'd like to watch the first part, you can still do so at sideeffectspublicmedia.org. In our first part, we focused on issues related to pregnancy and delivery, yes. And today we're going to focus on issues postpartum and in the first few years after an infant's life. Now we're going to throw it to Oshia Boyd, the editor of the Indianapolis Recorder, who is our moderator today.
Thank you, Lauren and Tony. Today we're going to turn our attention to the delivery and the crucial days, weeks, and months that follow a birth. Sometimes the outcome is good, but here in Indiana, we have too many outcomes that are not good. So let's meet today's panel. Today we have Ryan Kareem, a breastfeeding coordinator with Women, Infants, and Children, known as the WIC program. How are you doing today? We have Dr. Virginia Kane, head of Marion County's Department of Public Health. How are you doing, Dr. Kane?
Thank you.
Mm-hmm. Kelly Breen. Oh, I said those backwards.
That's okay.
I'm sorry. You are Ryan, and you are Kelly. So, and then we also Kelly Breen, you're program director for Speak Life, a pregnancy outreach program in Northern Indiana.
Yes.
And then we have Bronson Tucker Edmonds, an associate professor of obstetrics and gynecology at IU School of Medicine. Welcome, everyone. So, depending on the year and data source, Indiana ranks in the mid-40s out of 50 states, and the District of Columbia for maternal and infant mortality. Why? Can anyone want to start?
Absolutely. I think it begins with the health of the mother and the communication between the healthcare system and the family. It's broken, and it's been broken for a long time, and that's what we're seeing, the rates that we're seeing right now.
Okay. Anyone else have any ideas of what's going on?
So I think a lot has to do with social determinants. Mm-hmm. So we find that when we look at the data for infant mortality, the higher risks are in socioeconomic areas where there's a higher rate of poverty, and a lot that comes with increased poverty also comes with a lot of stress mm-hmm. that's related to, I've got to figure out, I may not have transportation, so I got to get on our bus system, and here our transportation system is such that there may not be grocery stores yes. where I live, so I have to get maybe my food at a 7-Eleven. And so I think all of those stresses are huge. And mm-hmm. I know at least in Marion County, we've seen our poverty rates increase. And think about this. Minimum wage has not increased in 10 years in this country. Yeah. Has not increased, but when you look at inflation, what you got to pay for your rent, your utilities, and everything, I think those stresses can have some impact.
Okay. Mm-hmm. So I understand what you're saying, your point about the stresses and poverty, but as we look across all socioeconomic spectrums, though, it still tends to be a problem for African American mothers and babies. So how do we add that into the equation then? How do we kind of lower the infant and motherhood mortality when it comes across all spectrums?
I think that I agree with both of the other two panelists, and I think that we have to stop being afraid of racism, which is the reason for the systems being broken, which is the reason for increased poverty, particularly in the Black community, not having fresh food markets in the Black community. I think that we need a massive overhaul of the system. Mm-hmm. We have to destroy the systems that have been put in place that prevent women from being in optimal health, that prevent families from having access to fresh foods, which ultimately leads to babies not having proper access to their first food, which is breast milk. And so I think racism is we can't be afraid to say that out loud. That is the reason that black women in Indiana and across the nation are dying at higher rates. That's the reason why our babies are dying at higher rates. It's not that there's anything inherently wrong with black people. There's nothing wrong with us. There's something wrong with the systems in which we live.
Absolutely. I'd like to piggyback on what Ryan is saying. I agree wholeheartedly. And I think that a lot of that, too, is the implicit bias and the way things that are working within the systems as well. I think for a lot of moms, there's the fear of the healthcare provider. A lot of the moms that we work with as doulas, we're hearing them say things like, I don't know if I can trust my doctor, but if I say something, I don't know what's going to happen to me. And that's a big problem when you're trusting your life to someone and you're afraid of them. So questions don't get asked or answered, and the issues that come up, they are swept under the rug until it's too late. And that's absolutely a huge problem.
So what she's implying a little bit is that too, what's the cultural competence of the provider that's taking care of the pregnant mom? And so I may be making recommendations to a mom, but it's so unrealistic related to my lifestyle. As a patient, you're saying, well, wow, this provider doesn't even have a clue what's going on with me. So the recommendations that I'm making, that he's making, is just so far off the chart. I've got to be concerned about his other areas of his expertise in taking care of me during my pregnancy. Now that's one point, but she emphasizes another point, and that is, both my colleagues here, is that we have to look at our system.
Yes.
We always blame the patient why their outcomes are not great, but just how great is our system? Yes. So, we know that mothers who are on Medicaid insurance don't do as well as if you're on private insurance, but they're dependent upon the system that's provided to them. So I want to make my prenatal visit, and I'm primed and I'm ready to go. Taxicab that's contracted by the system arrives 1 hour late after my appointment. I can't make it, okay? And I'm trying to make an appointment for my prenatal visit, and I may only have 1 hour in a day to make that appointment, and the line's always busy. Or I've called and I want an appointment with the doctor, but they're telling me, oh, it's going to be 6 weeks or 2 months away. So if I can't get in the first trimester, wow, I may have a poor adverse outcome.
Okay. So you guys bring up a lot of great points, but I kind of want to move, because we're kind of jumping ahead to some.
Oh, sorry.
No, we're fine. We just kind of wanted to make sure we talk about what postpartum is first.
Okay.
So that people that are watching and out in the audience kind of know what period we're talking about. Because it seems as if the riskiest period for mothers and babies is at delivery and immediately after. And of the babies we lose in Indiana, almost half are in the perinatal period. So define perinatal in this context, and then how it relates to postpartum, which for mothers, the official definition, what is that for postpartum?
That's an OBGYN question.
Sure thing. So the postpartum period has historically sort of been thought of, and unfortunately this is somewhat shaped by the way that insurance and things have sort of structured it. There's sort of been this 6-week window that people think of as sort of that immediate postpartum period. There's actually a lot of new emphasis in really thinking more strategically and sort of a fourth trimester, and thinking about the needs of women out, well beyond that 6-week window into sort of that first year after she delivers, especially when we think about maternal mortality. Those are actually inclusive of death deaths that occur all the way out a year after delivery, and thinking about some of the really critical points and opportunities for thinking about neonatal and infant well-being is really in that first year of life. So I think sort of the historic terms that we've used in terms of thinking about like 6 to 12 week window is a little bit myopic. It's a little short-sighted when we think about the overall and sort of comprehensive sense of well-being for women and families. And so I think
it's
even
kind of
that
arbitrary
term,
then. It's just kind of.
It's not that it's arbitrary.
Okay.
The 6-week window has been one that's been focused on because of the physiologic, the biological changes that have to sort of reset. So in that first 6 weeks, the uterus, which had to grow up to accommodate, a full human being, has to get back down to its sort of normal size, which is like the size of your fist. So you think about your belly is this big when you deliver, it's got to find its way to get back down to sort of its normal size. There's a host of changes in terms of additional like blood volume that you had to support, just all the changes that you can imagine biologically occurring for women to support the development of a human being. And so that process, the magic, that process has to kind of reverse itself to put you back to baseline. But even that, so there's a set of changes that should be sort of back to baseline, your healing window for your incisions if you end up with surgical interventions, things like that. That's usually sort of a 6-week window. But when we think about sort of really the recovery and what needs to occur, thinking more beyond just the biological to sort of beyond that. I think that there's a lot of good arguments and a lot of discussion right now about thinking more broadly about what that period should entail and not just focusing on the medical. And I guess that's what I mean in terms of some of the new conversation and thought that's being had about how to serve women well.
And is that where the perinatal comes in for the baby as well? Is that after birth or is that in the last trimester?
So perinatal actually extends, if my recollection is correct, in terms of vital statistics, is I believe the first 28, it's a window of time that extends from before delivery out to about 28 days of life. I think that's the perinatal window when we're talking about like perinatal death, for example, I believe is in the first 28 days of life. So it encompasses sort of this newborn period in a different way. And then we talk about infant mortality, you're talking about out to a year of life. So some of those terms are more, I would say, frankly, more useful when we're thinking about vital statistics, which is sort of the way that we count up, deaths and births and things like that, than they are in sort of day-to-day use, because I think that there are definitions that have meaning, but in terms of what we think about perinatal, it's sort of the time surrounding the time of delivery and then extending to the early newborn period.
So are there particular concerns for Black women and babies in this time period for either the postpartum period or the perinatal period? Immediately after delivery in your experience?
Absolutely. We see a lot in the hospital room, even before baby is born, that is a stressor to mom and to baby. A lot of times, some of our clients will say to us, I really would have liked to have gone through that contraction without being asked questions. Simple things like consideration for where she is in the moment, for where mom is and what she's feeling physically or emotionally as well. And then that's going to escalate. And that's going to be passed right on to baby. And then when baby is born, her stress levels, everything goes up. Postpartum is a really difficult point. Your levels are going down, your oxytocin is going down. Chemically, things change so rapidly that it's a big risk for mom and baby.
And we're seeing in terms of, and I know we're here talking today predominantly about infant mortality, or that's sort of the frame, but really in terms of that risk for maternal mortality, the postpartum period is key. We're seeing so much hypertensive disease with women having, we talk about the deaths, but the morbidity, which is sort of, we are seeing strokes in that window. We're seeing women with blood clots that can be life-threatening or can, seriously compromise their function. That window is actually a very, an at-risk window. We don't like to throw around that high risk and make it sound too scary, but it's a really important time. I think that's what's caused us to think more seriously as a community of providers in the OBGYN community about sort of what kind of surveillance and more points of contact we should be having with patients in that postpartum period, because that's really where we're seeing things manifest that are very threatening to the safety of women in particular. So not to take away from sort of the infant mortality piece, but when you talk about the postpartum period, it's a vital period. Emotionally, yes, we know postpartum depression is a huge risk. I mean, we know that there's the emotional front, but I don't want to underscore also that there's some serious physiological and biological, medical risks that come with that in terms of sort of what that recovery should look like. But unfortunately, what it can look like when we have baseline, differences and disparities in the health that women come into pregnancies with.
So that maternal mortality, I think, is really huge. I think New York Times did a great series about it a couple of months ago about the maternal mortality. And that's when a pregnant mom, after she delivers her baby, dies within 1 year from her delivery. And Indiana ranks 46 with the worst maternal mortality rates, 46 out of 48 states, going from 2011 to 2015. So we're really high up there with the maternal mortality, and like she says, it's heart disease, blood clots like Serena Williams that you can get, and 50% of that is easily preventable. If we are addressing it, but we got to know how to address it and do that surveillance like she's saying with the providers.
So kind of going into that, we have a video from hearings of the House Committee on Energy and Commerce in Washington. A man named Charles Johnson appeared before the committee to appeal to help to bring down the maternal death rates in the U.S., among the worst, as you just said, of the so-called developed countries. His wife gave birth to a healthy boy in 2016. But when it became apparent that she had abnormal bleeding, in the late afternoon, he and his family called repeatedly for assistance. A promised CT scan never happened.
It wasn't until after midnight that they finally took my wife back to surgery. After I begged and pleaded for them to take action for more than 10 hours. When they took Kira back to surgery, they opened her up and there were 3.5 liters of blood in her abdomen. And she coded immediately. Now, I'm here to tell you this. I'm not here to tell you what I think. I'm here to tell you what I know. There are people on this panel that are far more intelligent than I'll ever be that are going to talk to you about the statistics and how horrifying they are. But what I'm here to tell you is this, is there's no statistic that can quantify what it's like to tell an 18-month-old that his mother's never coming home. There's no matrices that can quantify what it's like to explain to a son that will never know his mother just how amazing she was. My wife deserved better. Women all over this country deserve better.
That was a very heart-wrenching video. Just, what can we do? So in Indiana, we have a couple of bills. Indiana has Senate Bill 360, which orders the state to establish perinatal care credentialing. Hospitals earn a level designation according to their ability to treat anything that should happen during labor and delivery. How will that help save lives?
Well, the hope is to try to really, with perinatal levels of care, is to try to have a better match on sort of the acuity or the seriousness of the healthcare needs with the services that are available to support women. So, for example, we have a high-risk service, at my institution at IU, and we're taking care of moms who maybe we know in their last pregnancy that in their postpartum period they went into heart failure. So we already know at very high risk to have a recurrence in that complication or to have problems during their pregnancy because the heart takes a lot of strain in pregnancy. Or they have other types of health health conditions that put them at high risk. So that's a patient that really, ideally, we need to have planning, we need to have partnership, we need to be talking to multiple teams, or take the patient who may have an abnormality with the baby, and that's a fetal anomaly that's known ahead of time. There's opportunity, there's time. We need to be able to get the teams on board to be able to transition that care quickly. And so that person isn't necessarily the person that needs to be cared for in the community-based hospital or in a rural facility, that doesn't maybe have platelets to help with blood clotting if this person is at high risk for bleeding. So it's more about trying to the extent that we're able to match, sort of the risk profiles with the resources that are available, and trying to do a better job in that regard. And then also making sure that sometimes you don't know ahead of time. Sometimes it hits the fan at the time of delivery, or things are unfolding, but having transfer and transportation protocols and expectations in place that this is not a child or a mom that should be cared for in this facility based on the resources available to this facility. It's not a fault to that facility, it's just that they're not equipped to care for every patient. So how do we make sure that we have adequate sort of, transportation, transfer protocols and things in place, but to basically make sure that patients are in the place that they can get the level of care that they need. I think that's sort of the idea behind it.
So it's just like a level, people get a gunshot wound, you go into the emergency room, you want to know if it's a level 1, meaning that's the most sophisticated system. So if I got a gunshot wound, within you stepping in that ER, you know that you're going to get that CT, MRI immediately. They're already prepping the operating room to do the surgery, and the people who, you don't want someone doing that surgery who's never done it before on you versus someone who's done tons of experience. So with these designations, the people out in the public will know, this is a level designated, and you're going to go an accreditation process to say they have this level of quality and this level of expertise. So if I'm in the ambulance says, wow, I can go to this hospital, but I can tell based on this patient, the severity of it, I need to go to this hospital because I know they have that level of sophistication and resources to handle this, and they have the experience. So that's the purpose of the bill, and I think it's a good thing. And it also sometimes encourages hospitals to develop that level of expertise, because I just don't want to be a regular hospital, and for me to get this designation, I'm going to bring those resources here so that I can, I'm going to raise the level of the services that I offer at my hospital.
I think parallel to that, and just as important, is the advocacy that goes along with that, because you can be at the very best hospital in the world, and if they don't want to help you, they don't have to. And I think part of that is having an advocate and allowing the mom to be heard. I think one of the most vicious things that happens is when a mom is silenced. And I think that her knowing what her rights are, her family knowing what her rights are. We've been working on a birthing bill of rights, talking about what it means to get the correct care, what your rights are as a woman, as a birthing woman in the hospital. And that means so much to know exactly what it looks like to get the care that you deserve, and having somebody there to advocate for you, to make sure to say, hey, we know you're doing your best, but we're watching you as well. And there's someone to hold you accountable for my life, because that's what this is about.
I hate to say that, the most excellent systems in the world, if you have a provider who does not listen, blows you off, and implies that you don't even know your own body, you can be at extreme risk for some adverse outcomes. And so that's the other issue. I think that, some of folks have, sometimes they mean well, but they have these unintended consequences, and they may not even realize sometimes that they're biased, so that there may be some competency training needs to be done about this. Do you realize that you may be biased? You're blowing this person off because you don't think she knows what she's talking about, but hey, let me just tell you, I'm a physician. And I've had physicians blow me off in regard to the care of my sister who had a kidney biopsy. And he was supposed to get some blood work done on her because I wanted to make sure she wasn't bleeding
Did he
as a
know who
result
you
of
were?
her kidney biopsy, okay? All right? He didn't do it. I called him up, and he wanted to know how I got his personal phone number, okay?
He didn't know.
And he got really upset that I had his personal phone call, and he says, well, no patients get my phone number. And I say, hey, I'm not calling you as a patient family member. I'm calling you as a colleague, okay? Have you heard of something called professional courtesy? But
Okay.
he didn't get the blood work like he was supposed to. And I was at a banquet speaking, so I didn't call till 4 hours later. And I got the resident on call to do her test. And guess what? She had bled out. She ended up in the intensive care unit. They were trying to do surgery on her. And guess who was there? And she's out of state. So guess who was there the next morning waiting for rounds with her in the intensive care unit, bled out because he didn't follow what he's supposed to be doing. And that's a physician asking another provider to do something. So what do you think of patients?
Well, that was my question.
What the patient is at risk?
We're not a Dr. Virginia Kane, so we don't have your professional
Advocacy.
Yeah, so like for you, Ryan, what do you think? What can we do? How can we better, I guess, advocate for moms and babies?
I think that to answer your question, I think the perinatal levels to care is going to be a great first step. And I also agree with Kelly that advocacy is very important, and doulas are very, very excellent advocates to partner with OBGYNs and other healthcare providers and parents. I think that education is a major factor, and I think that education begins advocacy. That's like the first step. I agree, Dr. Kane, I always tell people, when I'm talking to my family and friends or my colleagues and they, share similar stories of providers not listening, I always say, my final comment is always, and that's you. You're an educated woman. You were empowered to say something and advocate for yourself. And I just think of all the people, the women, the families that I serve who aren't. They're afraid of their providers. They're afraid to ask questions, or they don't know the right questions to ask. And so I think that educating families about what normal looks like so that they know when something is wrong is going to be very important. And I think that just encouraging families, telling moms, I always tell moms, you are your biggest advocate. And in terms of your baby, you're your baby's only advocate. Like your baby can't speak for himself. He can't say when something is wrong. And I think cultural humility. And so we talk a lot about cultural competence. That's a buzzword right now. Cultural competence, talking about, and I think cultural competence is built more on tolerance, and I think cultural humility is built more on, like you were just saying, trusting the patient. I trust that you know your body better than I know your body. And same thing with moms and babies, just trusting, taking what you say for what you say, learning your culture based on what you say it is, not what I've read or what somebody else told me or what I believe it is, because that is what implicit bias is just believing I know something about you just because you walked into the room. That kind of first impression kind of thing, and really judging a book by its cover. And I think we need to do more training in cultural humility.
Good point.
No, I was going to just add, in terms of thinking about the cultural humility piece, a lot of it, sort of my area of research is really around shared decision making, and it's a model of partnership where providers and patients are partners in the clinical encounter, appreciating that providers have expertise, right? We have medical expertise. We trained, Dr. Google. I still think I'm a step up above Dr. Google. But that said, we I think lose sight of the fact that patients have expertise as well. That they are expert in their lived experience, right? And that there are a lot of things that happen in medicine and in clinical care that actually we really need to have understanding and insight around that expertise that only the patient has, but we're not necessarily trained to appreciate it. And I think that that's where the cultural humility piece really comes in. I think of it or sort of frame it as just a sense of curiosity, of just a sense of appreciating that this person has lived a whole different life than you have, right? They may come from a culture and a background, have a whole history that's completely different. And you can't even begin to know what that is if you're not curious enough to ask, to engage, to invite their narrative and that information. And I think that it speaks to those differences you were talking about how we oftentimes are living entirely different worlds than patients. You know, talking about infant mortality, we're trying to give out cribs and to find out that patients are using the bottom drawers of their dressers because that's the one safe spot. And frankly, that's not a bad strategy for folks if they don't have if they can't put the footprint of a huge, because, you know, we're envisioning maybe where we live and being able to fit a pack and play when people don't have maybe that kind of space and square footage to, you know, and so really it sometimes requires listening and learning and appreciating that there's something that patients can teach you, and then trying to map on your medical expertise and what the resources that we have to provide, not to say that they aren't valuable, but they oftentimes are completely a misfit, right? Or they don't map to sort of that person's lived experience. If we're not doing the work to try to understand what that person's lived experience is, then we're missing, then it's you know, we're missing each other.
So let's move on. I'm sorry, Dr. King.
I think I'm going to blow your minds a little bit, too.
Okay.
Please do.
Okay. So I'm going to blow it. I'm just going to blow
All
it.
right, we're ready. We're ready.
Make it happen.
So I think that from an economic standpoint, you know, we have providers, hospital systems, and whatever, that we look at the economics of seeing you as a patient and how much time I can devote with you. There's something called RVUs. And RVU means that for this particular problem, I can only see you 15 minutes. For another problem, I can only see you 20 minutes. So you may have a patient trying to get comfortable with you or explain something, and the provider says, oops, I got my next patient scheduled right here. I really don't have time to listen to this, and so they won't listen sometimes, or they're discouraged in listening. So it's not like the old days when we used to see patients, you know, you could really spend that time with the patient and get to know that patient. So I think sometimes our system of looking at the finances impacts sometimes providers' behaviors in a way they shouldn't do it. So that's what you need to look at in terms of research.
I want to hold that point, but I want to shift to babies.
We're going to come back.
We got to talk about babies. We got to talk about babies.
Okay, do that research. Okay.
I have some thoughts about that. We can come back to it.
Well, don't forget them. Don't forget them. But I want to shift the conversation to the infants now. So there's a term that might be new to some members of our audience, periviable. It has to do with the stage of gestation at which a baby is born. Let's talk about gestational age, how it affects mothers and babies, and why it's particularly relevant for Black people. We're considering dads too in this discussion. So prematurity and low birth weight. What are we learning about the incidence of premature birth and low weight at birth among Black babies? And is there a specific number associated with what's considered low birth weight? Because when I hear that number, I don't know what that means.
So it means that a baby is born less than 5.5 pounds.
Okay.
You know, if you, just for the layperson's idea, so, you know, I had a 7-pound baby or a 6-pound baby, but it's a baby that's born less than 5.5 pounds. Okay.
Thank you. Thank you for that.
And they're different. So low birth weight is one sort of metric that we look at because we know that can affect longer term outcomes. But the other piece that you're talking about gestational age, prematurity, they're sort of different. Yeah, prematurity, preterm delivery, there's sort of different categories around that. So before 28 weeks is considered extremely preterm. And then there's sort of the 34 to 37 week window is sort of the late preterm. But really anything before 37 weeks is considered preterm. The reason that they have these additional gradations or sort of subcategories is because of how outcomes, we know that the earlier, right, the worse off in terms of outcomes, complications, lifelong potential, special needs or things like that. And so that's why there's sort of this segmentation in terms of whether are we talking about before 28 weeks? Are we talking about before 34 weeks? Are we talking about before 37 weeks? And then there's been a new push actually, even though you're term at 37, to really encourage the entire medical community and women's community to appreciate that the longer that baby can cook and that brain can grow and that body can develop, the better off in terms of those outcomes. So the new emphasis over the last several years to getting folks to 39 weeks, it's not about that, it's not that prematurity is not still technically by definition before 37 weeks, but we've just learned that there's a lot going on in that 2 weeks between 37 and 39 weeks that can be a real benefit to babies. And so we've been trying to encourage folks to, wait.
What, for example?
There's actually a fair amount with regard to brain development and growth in particular. That's one of the big areas that, and then lungs as well. Lungs and brains are sort of the big things that are still working on developing. Most of them are developed by 37 weeks, but we know that there's still a lot of good growth to be done between 37 and 39 weeks.
That's that psychomotor, the ability of that baby to walk, and even impacts their learning abilities. And then respiratory infections are huge. They may be more prone to asthma later as a result of
not making it to 39 weeks.
Yes.
I'll even add there's a huge difference in the coordination of a baby's suck at 37 weeks compared to 39 weeks. And so breastfeeding a lot of times at 39 weeks is, I won't say a breeze because it never is. It's never a breeze. But for a baby, they're more coordinated. So they're able to come to the breast and latch better at 39 weeks than they are at 37. And so that's that brain development, that she was talking about, that coordination, the ability to coordinate, suck, swallow, and breathe.
Nutrition.
Yeah.
Nutrition.
I mean, I have to say that there are circumstances where your baby's going to be better off outside than inside, depending on people who come into pregnancy with different kind of medical complications that unfold. So it is the case that sometimes there are recommendations for you to deliver earlier, but that is something that we take very seriously and only would recommend for women if it were somehow we thought the benefits to be gained from an early delivery were greater than the risk of the baby continuing to gestate and to develop inside of mom.
Now there's this concept of weathering. So what is the impact of weathering? The theory that stress, systemic racism ages Black women's bodies on prematurity and low birth weight. Is that something that you guys are familiar with? Do you think it actually does have an impact on Black women, their babies, their birth weights?
Absolutely. I think weathering has a lot to do with just the overall health of Black women, just by and large, but then where it comes to birth, pregnancy, and postpartum, when you talk about postpartum depression, add that to the systemic racism that she's been dealing with all of her life. That's huge. And then maybe not even having an advocate or someone to speak with or a way to release that pressure. We talk about socioeconomic factors and issues that happen in her neighborhood, lack of nutrition, living in a food desert. That just compacts and compiles, and it becomes more than what a lot of women can really bear, honestly, emotionally and physically.
And it will have an impact on the baby as well.
Absolutely.
Ryan, do you want to add something?
Oh, I was just thinking about, you said it would have an impact on the baby, and I think, absolutely. There's a study that was done in terms of postpartum depression, and moms were communicating with their babies, talking, laughing, and the baby was, babies coo back and they talk back, they participate, and then they had the mom go back in the room with a stoic face. No matter what the baby did, she was supposed to have a flat affect, and the babies were like distraught. They didn't understand their mom. It was like she was a vacant vessel, and that is like a prime depiction of what postpartum depression does. And so you think about the economic factors and the social determinants of health and postpartum depression and all these extrinsic factors. We haven't even started to talk about physiological issues and medical issues that mom may be experiencing. And so yes, weathering, it definitely plays a role. It definitely could impact. We know that stress can cause a mom to go into early labor, preterm labor. And we also need to be very, very aware that postpartum depression is, a lot of times it's not just postpartum. I think we need to think more broadly and think about perinatal depression. A lot of times moms need to be screened for depression in pregnancy because a lot of moms are depressed because of all the things that we have talked about in pregnancy. And so I think that, better support For moms.
We talk about support. I want to bring in the dads.
Yes.
Because we want to talk
Absolutely.
about the dads.
Yes.
So
Before we
what
talk about
roles?
that, can I just put one
Okay.
thing out there? Because one of the things that really, it hurts my heart, I will just say that, is the number of folks who are, who discontinue, people who are taking medication. I know that there's taboos in our community about medications for mental illness. There's taboos about mental illness,
Yes.
and there's taboos about medication for mental illness. But to see people who are actually in care on medications for various mental illnesses that are stable on those medications, and then they find out that they're pregnant and they stop everything cold. And then to have to try to really reassure them that they can take what I try to just, if I can message one thing to women, and the reason I interrupted you is that you have to be well. There's actually reams of data to support the fact that if your mental health is not optimized to the extent that it can be, that it will have negative implications and impacts on your newborn, let alone on you. And so I really encourage women, particularly if they're already, it's one thing to have a conversation about beginning medications, which is also can be safe in pregnancy, but I understand people's reluctance. But if you are on a regimen that is working for you and keeping you functional, that it is so important to talk about whether there's anything that needs to be changed for pregnancy. That can be something that needs to happen. But I think that I just get, and there are doctors out there who just, positive pregnancy tests, stop all your meds. And it's like, that is not the right answer. Absolutely, if you're not comfortable with it, consultation, get them in quick and early so that you can have those conversations. But women need to be well if their pregnancies are going to be healthy and if their children are going to fare well.
Well, I think this is still where dads come in at.
It is.
Yes.
Go ahead, Dr. King, you have something
So
to add?
the stress also, because I'm an infectious disease doc, the stress also causes increased inflammation.
Yes.
And if you have this inflammation going on for a long time, boy, does that impact negatively all your different organs in your body, the inflammation. So it's like those hormones are changing, and it increases the inflammation. So you can only go through that inflammation for just so long without causing significant wear and tear on your body.
Yes.
So when it comes to the dads, though, I got to bring the dads in. We don't want to leave out the dads because they are very important in this equation. Because a lot of times the dads are seeing what's going on. The dads see the mom under stress, under duress. The dads see the mom struggling with the baby. The dads see the baby struggling. So what role do dads play? How can dads support? Because we know dads aren't delivering the babies, but they're still there. They see the distress on the mom's face.
Listen, some of these dads are in distress themselves as
Yes.
a result of seeing all of this.
Yes, and they don't know what to do.
There's starting to be more conversation about paternal depression.
Yep.
Oh, that's a thing?
Yeah.
One of my colleagues recently just published some work around paternal depression. It's a real phenomenon.
It's a real thing.
We were just working on a review looking at dad's contributions to perinatal decision making, and largely the research that's been done. It's not a ton of studies that have really been done at this, but a lot of the work that's been done just shows that our systems of care, our obstetrical systems of care, are really, I think on one level they're rightly women-centered because that's sort of a point of pride and a point of focus for women's health providers. But I think that we miss sometimes that to the extent that the woman desires for their partner to be involved and engaged, and that person is a source of support, that's actually an important aspect for us to be inclusive of as well. And most of what's been reported out in the work that has been done suggests that dads feel pretty marginalized and pretty sort of cast aside in the obstetrical care space. And I will admit, in my own training, that I was almost in my 4th year of residency before I realized what an afterthought, dads were in the care I provided.
Well, yeah. So, it's so important for the dads to be part of the prenatal visit, seeing what's on the sonogram and watching what's going on. And they have a calming effect on their significant other.
They release that oxytocin.
Yes, exactly. Thank you. But the other thing is important, and this comes with breastfeeding. It's so important. A lot of the mothers look to see how their partners view breastfeeding, and
Yes.
it impacts
very key.
sometimes their ability, whether they're going to breastfeed or not.
I was actually going to say that the Indiana Black Breastfeeding Coalition did a poll of mothers, and to really my surprise, I thought most moms would say that their mom would be their biggest supporter, or the person they look to for the most support. But in fact, it was dad. Over 60% of the moms said that dad was their biggest support. They looked to dad for support for breastfeeding. And I think that this is an area, the fatherhood engagement is really an area where I think the Indiana Black Breastfeeding Coalition and WIC is getting it right. I think WIC has even gone a step beyond just including dads in education and talking to dads, inviting them to appointments. We actually have a fatherhood engagement specialist who's a dad himself. And so it's like for dads by dads. And so it really reaches fathers, because it's one thing for us as a woman to say, come on, dad, come on back to this appointment. Let's talk dad stuff. We don't know anything about dad stuff, right?
So Dr. Walter Laughlin has this wonderful fatherhood program that we're really trying to do a great job of doing more education to really encourage fathers to participate. So it's just huge. And we give out what we call, I don't want to let you know how old I am, but in the old days, they'll give out coupons. So if you make a prenatal visit, it's our BABE program, you get so many coupons or whatever. So we give extra coupons. If the father's involved, you get double the coupons because they are key critical person as part of their pregnancy.
We know as doulas, we talk and we laugh about it, but we know that sometimes when certain people come into the birthing room, things will happen with mom chemically as a matter of fact, physically. So if a mom tells me that she doesn't want mother-in-law there, and she really doesn't want mother-in-law there, the sound of her voice sometimes can slow labor down.
Really?
So sometimes just her presence and knowing that she has arrived at the hospital when she wasn't supposed to, that can shut mom down. We have that fight or flight system within us, and it works. Having dad there, having this man there who you feel comfortable with, that you love, that can change everything. Having that support, knowing that you have that advocate there with you, and she's going home with him. So strengthening that bond, there is no better time than birth and postpartum to let's do this together, let's be a team. And then he's that advocate as well, so it means a lot to have dad there. Absolutely.
Well, so breastfeeding was brought up. And actually, you guys are on it because we were going to breastfeeding next. So Side Effects, the Recorder, collaborated on a story about breastfeeding in the Black community in 2017. That report cited a study by the Centers for Disease Control and Prevention. It said that hospitals in zip codes with more than 12.2% Black residents were less likely than hospitals in zip codes with fewer Black residents to endorse breastfeeding. Comments. And we're going to stay here for a little bit, so we got a lot to talk about breastfeeding. I know, Dr. Kane, that's one of your big things. So any comments about this study?
Well, I will tell you that when you look at breastfeeding, the Hispanic mother has the highest breastfeeding rates compared to their white counterparts, and African American women are the lowest in terms of breastfeeding, in terms of the percentage who breastfeed. And what I will tell you is that there are a number of factors I think that's related to it. It's one, do you have family support and encouragement to do breastfeed by your significant other or your parents or whatever. So I think that's key. But also I think sometimes it may also be related to your job. So if you, we find that a number of employers, especially if you're in a low economic job, position, that the employers don't encourage that in their setting, or you need to take time to do the pumping of your breast milk. So they don't encourage it, and so it's it's in a setting where people may be commenting or teasing you and blah blah blah. So it doesn't happen, and it also maybe you've got two jobs and just the logistics of trying to get things done may not happen. So we've got a lot of work to do, because half the battle, we know that if you breastfeed, it's definitely going to cut down on respiratory infections for your baby significantly. We definitely know it's going to cut down on your child being at higher risk for obesity. It's got so many positive things, and just the nutritional value alone, that brain development, I can't tell you how critical that is related to breastfeeding.
Yeah, there are lifelong benefits for sure. I think that a lot of women, I feel, particularly in the Black community, so kind of piggybacking on what Dr. Kane said, I think a big factor is support in the family. I also think that going back to work, we know that in this country we hardly have any maternity leave. A lot of, and I recognize my own privilege in the fact that I was able to stay home. I had a maternity leave when I had my children. A lot of the women that I serve don't. And that was one of the biggest lessons I had to learn. When I started doing this work, I talked to a mom and she'd be like, yeah, I need a pump. I'm like, well, why? Your baby's 2 weeks old. And she's like, well, I'm going back to work. And I'm like, oh, girl, please, you need to sit down, like the old schools, your body needs to heal. You can't go back to work. And so one of the biggest, she doesn't have leave. She doesn't have, she's really behind now because she's taking these 2 weeks off. And if she was going into preterm labor, maybe she had some time off before, on top of all the appointments when she was pregnant, that adds up. And so she's got to go back to work, feet hitting the ground. And so I think that a lot of moms think that breastfeeding has to be all or nothing. And we know that that's completely not true. I think that, again, another hard lesson I had to learn as a supporter of breastfeeding is that we always want to push exclusive breastfeeding, only breast milk. And of course, we know that there are benefits. All the research says, breast milk for 6 months is all a baby needs. However, any breast milk is better than no breast milk at all. And I think that we need to start pushing, having more conversations with moms about offering breast milk at all, even if she can, if she needs to supplement a little bit. Hey, that's fine. Breastfeed at home when you come, home in the evening. Speaking to having a place to pump at work. In Indiana, we have a law that says that not only that moms have a right to breastfeed anywhere they have a right to be, but any employer that employs more than 20 employees, they have to provide moms with a space to pump and a safe place to keep her breast milk. But a lot of employers get tricky about that, and so they might have a place to pump. If a mom works on a factory line, sure, they have a place to pump, but it's all the way up in the offices where the people who sit behind a desk are, and it might take her entire break time to walk up there to pump. Or because she leaves the line to pump, the line has to stop. There's nobody to step in to take her place. And I think that we need to do a much better job in the nation and definitely in our state about really supporting moms in the workplace and giving them more options in terms of how they feed their baby. Breastfeeding doesn't have to be all or nothing.
I think to add to that, we have to look at the stigma surrounding breastfeeding for Black women.
Oh, yeah.
Because we know historically we were nursemaids, and the pictures of the slaves nursing white babies, and that gets burned into our brains and we see it, and it became, after a while, it was like, oh, I have money, I don't have to do that. So now I bottle feed, and it became this thing where, you had money or you had status, you didn't have to breastfeed. And we need to remove that stigma as a community, as Black women together, but we also need to see more pictures of Black women nursing. When you see a beautiful pamphlet, or you see a picture or a poster, it's a white woman who's nursing, and it's this beautiful, this image. But if you Google Black woman nursing, dear God. And if you go to, and if you go to clinics and doctors' offices, the images that you see, they're not relevant to us, and they don't encourage us as Black women to be proud to breastfeed and to really see it as natural and beautiful for what it is.
And there's sort of also, I think there's so much culturally that's packed into it, because the other piece is sort of the hypersexualization of Black women and the Black female body. And so this idea of what it means to have sort of a culture that embraces sort of exposure in that way, as opposed to chastising it or shutting it down. There are a lot of messages that say that that's not okay, when in fact that how do we reframe that to be that's beautiful, that's life-giving, that's but we have there's just been so much that's really been put on us that's not even really about us, that has kind of kind of twisted the depiction and of what's sort of healthy
And sadly,
about
we've
our
absorbed
bodies.
it as well.
Yeah, exactly.
We take it on just naturally,
Yeah.
sadly enough.
Yeah.
So Ryan, you mentioned 6 months of breastfeeding. That seems like it's like a magic number. The Indiana State Department of Health included an interesting fact in its 2016 report on infant mortality. If 90% of U.S. families comply with medical recommendations to breastfeed exclusively for 6 months, the United States would save $13 billion per year and prevent an excess of 911 deaths. That's astonishing. Now I know you talked about if you can't do it exclusively, but do it here and there. But what is it in that 6 months if you breastfed exclusively? Why is that so important that it yields us such extraordinary benefits?
When the baby is first born, their digestive system is not completely developed. And so I liken it to, ironically enough, is what I tell my moms, the Pepto-Bismol commercial, okay? So you've seen upset stomach diarrhea, right? They show the person who's got diarrhea, they drink the Pepto, and it goes and it coats the stomach lining to help to strengthen it, to make them not feel so queasy. And that's exactly what colostrum does, which is the first breast milk. That's exactly what it does for our babies. It goes and it coats the digestive system, plugging in all those little holes to protect the baby from getting sick. And every time baby gets breast milk, we get a new layer of protection. And it's not until the baby's 6 months old that the digestive system is completely healed. That's just one protective factor. Of course, we know that when we breastfeed, we're holding our babies. Breastfed babies get a lot more interaction with mom. A mom who's breastfeeding, she's looking down at her baby, she's talking to the baby, baby's engaged in conversation with just other adults, so there's a lot of brain development happening. If you've ever seen somebody bottle feed a baby, typically the bottle's hanging out, maybe if they're holding the baby, right? Sometimes we prop babies up, which is we shouldn't be doing. But if we holding the baby's kind of looking that way, you're holding the baby, you're holding the bottle, you're looking around, you're doing other things, you are not engaging with the baby. And so bottle-fed babies don't get as much brain stimulation or brain development as as breastfed babies do. So, there's an endless list of reasons why 6 months is a really magical number for breastfeeding, exclusively breastfeeding for 6 months. Those are just two really good benefits of it.
And also, infants, their own immune system actually sort of kicks in around that 6 months in terms of developing its own antibodies and things like that. So there's also sort of a protective mechanism in that regard.
Yes.
So, there's many factors and variables.
Where can moms get support during that 6 months? After they left the hospital and they're still trying to breastfeed, but maybe they're having some issues or, things aren't going quite the way they planned. So where can they get support in that 6 months time period to keep them encouraged?
I'll repeat, doulas.
And lactation consultants.
Yeah, lactation consultants.
Absolutely.
WIC is a wonderful resource for breastfeeding. Every WIC office in the state of Indiana has breastfeeding support, so moms can certainly go to WIC. The Indiana Black Breastfeeding Coalition is a resource. There are lots of resources embedded into communities, and I think providers, of course, community-based organizations need to do a good job or a better job of letting providers know that they're available. And providers need to do a better job of referring moms, hospitals. There should be a bridge to gap hospital to home. There's no, day 3 is the day that most moms quit breastfeeding, right? That's when your mature milk comes in, your breasts are huge, they're hot, your baby all of a sudden doesn't know how to latch, even though breastfeeding was going beautifully in the hospital, right? All of a sudden you don't have all the extra hands to help you get things together. And so there should be a bridge to that gap so that moms know when they go home on day 3, day 5, when they're really struggling to make things work, they should have support already in place. Moms shouldn't have to get on Dr. Google to figure things out. They shouldn't have to be looking up resources. There should already be something in place. And a lot of times there's something available. Moms just don't know where to find the support.
Yeah. Dr. Kane.
Oh, I'm good. We can always. A lot of health departments have resources too, and we have a WIC program. We have breastfeeding support and training available. So I just really think it's just really critical. But I do think we have to devote a lot of attention, not just educating the mom about the importance of breastfeeding, we equally have to do a great job with the partner
Yes.
And the care provider as well.
and the care provider.
We've had moms who have, right after labor, having maybe a C-section, been given meds that were contraindicated for breastfeeding. So baby's not nursing as well.
Wow.
And we're trying to figure out why baby's becoming failure to thrive. Well, she never should have had this medicine if she's going to be breastfeeding. She didn't know. Doc either didn't know or didn't pay attention to the fact that she was breastfeeding. So then we've got this child who was beginning to suffer when it was simply a matter of changing the med. So healthcare providers need to be educated and be held accountable for what's going on with breastfeeding with these moms.
Well, we are going to pause for questions.
Okay.
As you can imagine, they are pouring in, ladies. So the first question is, what level of coordination takes place between doulas, midwives, and OBGYNs? Could that improve outcomes? And could the midwifery model be considered as part of the solution?
Wow, that's a loaded, beautiful question. It is. There's a multi-tiered answer to that. The communication between midwives and doulas traditionally has been very close because they're older professions, and one naturally stems from the other. Having a midwife doesn't necessarily mean that you have a doula, but midwives and doulas have been kind of a closer profession to each other than OBGYNs, but the communication can be seamless between all three because they all have different roles. An OBGYN being able to do the clinical and the surgical, the midwife knowing kind of the more holistic routes to take, and the doula being able to understand each of those and then translate that to the parent means a lot. But that communication falters sometimes where maybe OBGYNs or maybe midwives don't understand the role of a doula if they haven't been educated and they feel like the doula's coming in to step on toes. Or they may kind of be averted to like, okay, you're in my space. But when it becomes communication, say mom is having an interesting time during transition and there are things being said and the room gets thick, a doula can speak with the nurse and say, hey, you know, she's had a rough night last night. Can she get through these next few contractions? And we talk about this later. Just kind of being that bridge for either the OBGYN or the midwife so that there's that buffer and there's someone to change the atmosphere of the room, because that can make all the difference.
Yeah, I think historically there has been, I don't know if it's been about threat or turf or what, but I think that there is some mending and some opportunity to really help for the, I'll speak as an obstetrician, for our community to really, I think the biggest leap forward that we've made in recent years has really been embracing midwives and the midwifery model more. I mean, the American College of Obstetricians and Gynecologists, like we have at our legislative meeting every year, we have the president of the American College of Midwifery, who comes. So there's been a great deal and an intentional effort to work more closely together to sort of embrace and appreciate how we can complement one another in terms of the services and the expertise that we offer and that we bring to bear on maternity care as two professions with different kinds of training and expertise. I think with regard to doulas, I do think that there's still sort of ground to be sort of gained there, because I think oftentimes there has been a sense of this question, even with sort of the language, I think of sort of, that we're there to advocate for the patient or to help the patient, exercise their rights. I think a lot of times the obstetric and the physician community feels like, I'm not the enemy. I'm here trying to help this person have the best experience they can too. And we know the reality is that everybody isn't maybe meeting that standard. Everybody maybe isn't there for the right reason. But most people, for the amount of work and hours and the sacrifice that it requires to be in this profession, feel like they are doing it because they want to help people. So then this sort of, there's a sense of threat or defensiveness about, who is you advocating and protecting her from who? Because I'm just here to help, So I think that there's some work that needs to be done with really opening those lines of communication and starting those conversations earlier so that everybody can figure out that we're on the same team and that we play different roles and that we have different, expertise to offer. and that we actually could be working together in a way that could really serve women better. So I definitely, there's room to grow, but I do think that the midwifery model, in that it's just women-centered, is one that has, and that it focuses on what's normal about labor and delivery, has, really huge benefits. I always tell people I learned everything I know about normal labor and delivery from midwives, because we had midwives who were on faculty where I trained at Duke. And so, I've grown up in a culture very, not even accepting, but kind of reverent of midwifery and what it has to offer, but that's the exception and not the rule. So I think that there's work to be done.
I think that's particularly true in Indiana. I always say that when Indiana is so far behind in terms of women and children's health, because there are so many states that have excellent models where they do work together, and it isn't the exception, it is the rule. And I think Indiana, there are a lot of midwives. That's not true. There are not a lot of midwives in Indiana, but we do have people from Indiana who go to become midwives. And a lot of times they leave our state because there isn't work for them, or because it is the exception and not the rule, where they would be able to partner with an OBGYN or, I think we can do better in Indiana in terms of the midwifery model of care.
Here's another question. It's a little long. In the media and educational resources, it seems that the blame is placed on the Black mother for not informing themselves better about breastfeeding and for not educating themselves earlier. All the responsibility and fault seems to be placed on us. I come from a family of breastfeeders, and the fight for the right to breastfeed in the hospital was unbelievable. Formula was pushed on me several times. I was met with a surprise and reluctance each time I requested a lactation consultant. My income came into question each time I tried to rent a pump or purchase donor milk. If I didn't have such a strong family history, I would have been defeated. My white friends did not seem to have this same experience. My question is, how much work needs to be on both sides, medical professionals and parents, to support Black mothers for a strong start to breastfeeding in the hospital? How do we work toward that point for a better partnership?
I'll start there as on the provider side, the sort of physician side, because I think that one thing, I don't know if I want to call it implicit bias, but I'll say it's an implicit attitude. I think that there's sort of, and because of those statistics, right, like, sort of these sort of stock notions or stereotype notions are born out of, statistics and things, so it is true that breastfeeding rates are lower in the Black community. But what that does not mean is that for any given individual woman that you can assume that they don't want to breastfeed, or that that's not a part of their plan, or that they can't be, sort of convinced or educated and informed and make the decision to do so. And so I do think that with providers, we have to be careful that we're not starting from the place of the assumption that this Black mother in front of me is not going to breastfeed, not going to be open to it, or is going to be defensive about it, or something like that, And I think that we carry some of that. And maybe it's because the last 5 Black women I cared for didn't want to hear about it, or said that their grandma told them this or this, that, the other. But you have to, again, back to that issue of humility and curiosity. Like, you have to start with each person anew and appreciate them as an individual without regard to what kind of your experience has sort of maybe primed you to expect or presume about what their preferences are going to be. So I think that plays into, what she is describing is just unacceptable. There's no really excuse for those kinds of pressures, but I do think that sometimes providers don't even realize that they're sort of starting from a place of assuming that they know. And that will always get us in trouble when we assume that we know. So,
I also think, first, that breaks my heart. It's a story that, we hear all too often in terms of not just breastfeeding, but in healthcare in general. And so that really, it breaks my heart to think that if she hadn't come from a family of breastfeeders, that she probably would have given up. But I also think this is an opportunity for us to talk about the importance of representation. Representation completely matters. And a mom, to answer her question, it is 100% a mom's responsibility to learn everything that she needs to know about pregnancy, about the expectations of labor and delivery. the information is out there. We live in the age where education is at your fingertips all of the time. And so it is her responsibility, but it is not only her responsibility. And so she should be getting education. Prenatally, we know that moms make the decision about how they're going to feed their baby in like the second trimester. And so we can't have these conversations postpartum at, in the delivery room, like, hey, mom, you're going to breastfeed. That's a conversation that we should be having with mom prenatally. Every appointment, we should be dispersing little bits of information about breastfeeding. So that way, even if mom was a little bit turned off that you asked her the first time, you keep talking to her about it a little bit at a time. Maybe she'll raise an eyebrow about some information that she didn't know. Maybe she'll hear something that was important to her. I know for me, learning the protective factors against breast cancer, that was important for me because it runs in my family. And so maybe I wasn't going to breastfeed, but after hearing that, I probably will, because that's a big deal. And so, and also representation opens families up to feel a little bit more comfortable to talk about the hard stuff, to ask those questions, because you feel like maybe we come from a similar place. I can't tell you how many times I walk into a patient's room and they sigh a relief because they can ask me stuff, or maybe they feel like I'll understand if they maybe don't want to breastfeed, they only want to pump, for whatever the reason might be. And so I think we need more representation in the maternal care industry. We need more representation of doulas, of midwives, of OBGYNs, nurses. We need more representation so that patients can get not like white providers don't give them the care that they deserve, but representation certainly matters.
Yes, it does.
Well, then you have to also make room in the community for that too. Who are you hiring? Where are you pulling the doctors and the midwives from? And how affordable is it for me to begin training as a midwife? How does that work in my community? And that's huge. Starting off my career personally, it was very difficult. I'm robbing Peter to pay Paul to put together the money to do the things I needed to do just to support my own community and to educate myself. So that's huge. We have to look for scholarships, we have to look for grants. Well, okay, so where do we start? But that conversation also happens in schools. What are we talking to our young girls about breastfeeding?
For sure. Our
daughters, our teenagers, when are they getting this education about breastfeeding? Because we talk to them about everything else, don't we? Because if we don't, we should. But that's a huge area that is missed in sex education, health education. It should be a normal conversation. It shouldn't be strange, or stigmatized.
Agreed.
Either. So.
I agree with that.
Dr. Kane, this one is for you.
Blow our minds, Dr. Kane.
Dr. Kane, what are your thoughts about research being done to study a possible link between women vaccinated early in pregnancy with a certain version of the flu vaccine, who also had been vaccinated the prior season, having an increased risk of miscarriage? And this is based on the CDC-funded study by Dr. Amanda Khan, Senior Advisor for Vaccines at the Center for Disease Control and Prevention.
So I know that there was a study that was done where they looked at flu vaccination in young pregnant women. I think they're between the ages of 18 and 44. And they looked at a little bit less than 500 of the pregnant women who had received a flu vaccine. Now, this was during that 2009, 2010, where we had that first H1N1 came on the scene, and it was one of the most virulent strains of the flu ever that we've seen. And they are stating that there's not a causal link, but there may be an association of miscarriages with this flu vaccination, was what the authors are saying. And one of the things when the CDC, I think, really looked at that data, they've had tons of data. There have been like 3 or 4 tons of studies that have looked at the vaccine adverse reporting system and could never see a link or a correlation. So they were concerned a little bit about the research design, because when you make recommendations like that, you really have to see thousands of women in a study to really see if that's really a true link or a true association or not. And I say that because sometimes women who are at higher risk for miscarriages may be the same type of women who are more likely to get a flu vaccination compared to your control group, so that the results might have been a little bit biased.
Okay.
But they are doing a huge study. We're repeating a huge study, and I think the results are going to come out actually this year.
Okay.
And I know Dr. Haywood Brown, who was just stepped down as chief of OBGYN at Duke and was the president of ACOG, and a number of their OBGYN researchers looked at this very carefully and felt that we should continue to recommend strongly women getting the flu shot during their pregnancy.
I think the piece that
Yes,
people
please.
don't see from the obstetrical, so it was interesting, we were just chatting about the study, it came up earlier, and I was thinking, well, oftentimes people will get their flu shot later anyway. Like there are a lot of vaccines that you really are only supposed to give in the third trimester, so oftentimes we're kind of grouping them, even though you can safely administer it at any point. A lot of times we're in our practice typically sort of doing it a little bit later. So I was surprised that it was the miscarriage finding, because you think about, they're usually talking about early losses. But with that aside, I think that you have to always, with anything, look at sort of risk and benefits. And I think sometimes people miss the risk because women, like pregnant women who get the flu, are at very high, like 10 times the regular population, very high risk of dying and of having serious consequences. So that, developing the pneumonia, ending up on a respirator, and it happens so infrequently, right? In absolute terms, people are like, well, that's, nobody's ever seen that, and then everybody knows somebody's had a miscarriage. So, by comparison, it's sort of hard to bring that. It's sort of hard to put those things, it feels like apples and oranges on some level. But I think it's really hard as providers who have seen women in ICU because they have, a flu sort of related complication and are basically not able to breathe on their own anymore from a pneumonia that's just gotten out of control. Like these situations just stick with your provider. So we know that the flu is actually deadly in pregnancy, and we think that it's important to try to protect people as much as possible. Again, I do know that my mother included, that we have all kinds of mistrust about the flu vaccine and every other vaccine in our community. I know that, but I think just so that people can understand where we come from as providers who are encouraging it, I think it really only takes one sometimes awful outcome for you to really change your whole perspective and to feel like this is a good and there is risk on not taking advantage of this benefit that this could offer you. So that's just kind of where we find ourselves as people who take care of women and see sometimes the worst outcomes.
And then the other thing is that it's really important that there are two types of flu vaccines. One was the nasal spray where they got an actual live flu vaccine and they just weakened it to give it to you, versus a man-made flu vaccine that's genetically made, but it's not a live virus. And so you should never give the weakened live flu virus to a pregnant mother. It should only be the genetically man-made, but it's not a live virus. So sometimes people, unfortunately, will get the wrong flu vaccine, and that's really critical. But trust me, we can't
that's
start.
Good to know, though.
We
that's
can't.
Good to know.
Yes, that's very important to know, because providers do not, unfortunately, always know that that's the case. And we were heavily using the nasal spray flu vaccine at that time that this study was done, but. You don't start the flu vaccine until you're 6 months and older. So not only does this flu vaccination impact the pregnant mother, it reduces their risk of 50%, prevent them from getting the flu by 50%, but it protects that newborn baby because mother's antibodies go across to the newborn baby. Will protect them in that 6 months where you can't vaccinate or protect that newborn baby. And we've had a number of children who died from the flu. In Indiana now is experiencing a high flu activity, and so please get that flu shot.
Get the flu shot.
Get the flu shot.
I'm working on my mama.
So here's another question.
Please work on your mother. I'm trying. Have your mother call me. Have your mother call me. Okay.
So a study from 2016 is titled Suboptimal Breastfeeding in the United States: Maternal and Pediatric Health Outcomes and Costs. This study shows how breastfeeding results in lower health care costs and reduces numbers of diabetes, heart attacks, and maternal hypertension cases. Surveys show that roughly 60% of women are not meeting their own breastfeeding goals, Bartik said. That's the person that wrote the study. Mothers want to do it, and doctors can play a major role. Breastfeeding is a topic not often discussed between pregnant women and their medical providers. Please comment on what is being done and or planned to improve the breastfeeding support that we offer to women in Indiana.
Well, I can speak from the provider standpoint, but I can't, you have to say for the Indiana writ large. I was just going to say that I do think that a change is coming. I mean, because, and again, I'm getting old, but I feel as though ever since in the time that I've trained, and maybe I've just trained it in excellent places, but breastfeeding has always been on the radar and actually front and center, and something that I've just been sort of brought up as understanding that this is something we should be recommending and encouraging, talking about throughout prenatal care. So I think that that is the guidance that is coming, at least now, if it hasn't historically been coming out of the professional organizations that provide guidelines and guidance for prenatal care, the American College of Obstetrics and Gynecology, et cetera. I think that there is a new emphasis, or maybe it's not new, but at least I know currently there is clear agreement that this is something that is good for our patients, good for their babies, and that we have a role in talking to them about, encouraging them. I do think that we also need to start to be better educated and have more of that conversation about where to refer, because I don't necessarily think, like you said, once people are discharged from the hospital and a lot of the troubleshooting, when it gets real, and it's hard, and I think that that's not necessarily, you said, I don't know, when you asked what can be done and who can encourage and what are the supports, I didn't pipe up, because I think oftentimes you can call your provider, but it's already going to be hard to kind of get back in. And like I said, ACOG, we're now trying to encourage people to schedule an earlier postpartum visit than just the 6-week visit, because there's so many needs and so much support that moms need. So that's one of the new recommendations, even though it hasn't been a big shift in practice yet. But yeah, I do think that equipping the provider community with the resources that we can partner with to make sure that people can have more coordinated care, I think is going to be a big piece of the puzzle. I think realistically, I don't see OBGYNs becoming breastfeeding experts. But again, we don't all have to have the experts in everything. Right. We just have to value and respect the expertise that one another bring.
So I think, our health department has a fetal and infant mortality review process, and actually was initiated by Dr. Haywood Brown, who's past president of ACOG, I meant to have said, to American Obstetrics and Congress of Obstetrics and Gynecology. But we are, Dr. Nancy Switkowski, who is a nationally known pediatrician at Raleigh Hospital, and does a lot with SIDS deaths, having the babies sleep on their back, which tremendous amount of infant mortality, but we're doing an initiative with a number of the black churches, Reverend Moore, who is the president of the Indianapolis Black Caucus, where we're trying to go to churches and actually trying to identify ambassadors. And we really want the males as the ambassadors, really we want to educate and train them about breastfeeding and how important that is. And we want to also educate them about preventing SIDS deaths. And so really trying to get not your usual partners being the ones out there educating about the value of this. So look to hear some more radio spots, announcements, and trying to publicize this. And we work with the Indiana Minority Health Coalition. The Marion County Minority Health Coalition puts on one of the largest pregnancy programs in the state of Indiana, where they have about 700 pregnant mothers. But what was great is about 40% of their partners were there at that event. So we're really always trying to get this education out. But the more we get out, the better, because we still have too many SIDS deaths where babies are dying and 78% of those deaths occurred in an adult bed where they were sleeping with an adult and they got smothered or strangled accidentally because they were sleeping with an adult. And also, it's so important to have them sleep on their back.
Can I ask if there are resources? This is really just as a question. I think for breastfeeding moms in particular, right? Obviously with nursing and I'm not in any way saying that breastfeeding puts you at risk for SAVES. I'm just asking, what are sort of the guidance around safe sleep? Because I know that it is one of those things that's just a challenge with the fatigue and what is that? Does that go hand in hand with some of the breastfeeding messaging that's happening about trying to reinforce safe sleep notions?
So can I chime in?
Yes,
I want to
please.
save this for final thoughts. This could be part of your final thoughts.
Okay. Sorry.
Okay. Because we are actually almost out of time.
Oh, okay.
But we do have time for final thoughts.
Okay.
So if you can get that question answered in final thoughts, that would be great. So in your final thoughts, what are future efforts to improve health outcomes for Hoosier moms and their babies? And we'll start with you, Dr. Kane, since...
Oh, my goodness.
Well, since Dr.
All right.
Since she was already addressing the question to you a little bit, so...
Wow. I think the city has to embrace really trying to increase, number one, the poverty levels for our residents here. We need to figure out how do we raise minimum wage where they are making living wage. That should be the lowest wage people should be making in Marion County. And I'm excited to hear that there are a number of some organizations here, I think United Way, Central Indiana Foundation, CICF Foundation, and some other folks are going to be really closely looking at this issue so that if I got a job, I'm working, okay? But if I'm working, I'm not making enough money to pay my rent and my utilities. That's tough. And then if I'm working 2 jobs, how can I take care of my children and my babies? Just trying to survive. So that's number one on the list. And I honestly think we have to tackle smoking. We have to tackle addressing safe sleeping on your back. And I think we have to tackle breastfeeding. But the most important point is I've got to get them in the first trimester. Okay. So I need hospital systems. We're begging you. Make it easily accessible for the mom to get in for her first prenatal visit. And it doesn't have to be a doctor. Well-trained nurses, other folks can start those prenatal vitamins early, do the health education, do their blood work and everything. And so, but get them in because, they have to have at least, we say, 6 or 7 prenatal visits to have a good, healthy outcome.
Okay. Kelly?
Thank you. Supporting advocacy, supporting the Birthing Bill of Rights, supporting those who are going into the homes, going into the hospital, making it available for Black women to be nurses, midwives, doulas, and making it a part of the system so that advocacy is there and there's a support in policy so that there's all-around care for our Black moms and babies.
Ryan?
I think that we need to get back to a lot of our traditional practices. I think we need to get back to celebrating motherhood. So often in the Black community, having a baby is something that is not celebrated. When you tell somebody that you're pregnant, when a mom tells me she's pregnant, the first thing I say is congratulations. And sometimes they're shocked because I'm the first person to have told them congratulations. And I think that rallying around mothers, it takes a village to raise a child, not putting all the pressure on the parent or the provider or anybody. It's going to take a collaborative effort, everybody working together to improve our outcomes.
Okay, I'm trying to get my racing thoughts together. So I'll say 3 things. One is that I think that particularly because of so much of what drives our infant mortality and maternal mortality are racial disparities. So I think that until we're really ready to have serious conversations about systemic inequity, racism, and all of the ways that continues to undermine the ability to have healthy Black communities. This will continue to be an effort that we're going to be making,
talking about it.
And making barely a dent in. I think that there's something about obstetrical care and maternity care that we've seen throughout history has sort of moved away from a focus on women and centering women and their families, that I think that we are beginning to have conversations about, but it's key. I think some of the efforts to partner with midwives and think again about centering pregnancy and different kinds of models for providing prenatal care. Those are opportunities. I will say, just as a caveat, because that not everybody who calls themselves a midwife is a certified nurse midwife. I just want to make sure that people understand that there are some distinctions. That's another day's program, but make sure that you kind of inform yourself about the credentials and the training that women have, or that people have, if you're going to entrust your care to them. And then the last thing that I was thinking about had to do with okay. I'm just going to say this because it hasn't come up and it's our last time, and I would be remiss. I think that there is a lack of understanding within our community about sort of family planning and birth spacing that hasn't been addressed, that is an important driver of prematurity and therefore infant mortality. And we, again, I brought up all the taboos. We know that there's lots of mistrust about contraception and in our community, but I think that it's really important to start with what is important to women. Everybody's top goal is not to not get pregnant. So maybe, everybody's top goal is not, about exclusive breastfeeding. So starting with what's important for them, and then letting it be our job to bring them the information, the resources that they need. If their big important focus is that I need to finish school and I don't want to have another baby for 3 years, then we have contraceptive methods that can facilitate that for you. If their most important goal is that I will be so proud if I can do this for 6 months, if I can breastfeed for 6 months, then maybe that's a different emphasis. But I just, I want people to start with the woman. No, you gotta cut me off.
I don't mean to cut you off. I don't mean to, yes, but we're about out of time.
We're out of time.
Yeah.
18
months
is the World Health Organization.
I want to thank my guests for being on this panel. It's been a great discussion, and thank the audience. No, you're fine. This just shows how much we need to talk. We need to talk more and more about this subject. So today's conversation will be available on YouTube shortly, and you can also view part 1. Go to Happier Birthdays. Thank you.